Hello, everyone, and welcome to the Diabetes Alert virtual town hall born out of the DR Barometer program. My name is Supriya Vanegala, Project Officer at the IFA, and I will briefly review logistics. A reminder that this town hall is recorded and will be published on the IFA Facebook page. The town hall begins with opening remarks, which will be followed by a moderated question and answer session. Please use the chat function along the bottom of your screen to indicate that you have a question or a comment, and we will call upon you to pose your question. If you have resources to share, please post them in the chat as well. Video recording and resources will be compiled at the end of the town hall and posted on the IFA virtual town hall resource page, as well as the DR Barometer resource library page. Following the town hall, you will receive an email with an invitation to the next town hall in the series. Now, the COVID-19 pandemic has changed and challenged healthcare systems across the globe, and populations are continuously learning and adapting to all the new information being rapidly generated. It has become painfully clear that our healthcare systems were not designed to deal with a crisis of this scale. And at-risk populations, such as the aging population, is especially vulnerable now. There has been an increase in virtual care, changes in human behavior when seeking healthcare, which has resulted in a decline in emergency room visits, as well as a drop in planned life-saving, vision-saving surgeries. We really need to talk about those with vision impairment and the urgency of avoiding irreversible vision loss. We are going to be in conversation with Professor Tariq Aslam today, who is an expert in medical retinal disease, including the psychological aspects, diabetes vision care, and the use of technology to enhance patient care. Professor Aslam gives us a status report on care for diabetes-related vision complications during COVID-19 and highlights the opportunities identified and adapted for quality care. Let me tell you a little bit about our speaker. Professor Tariq Aslam is a consultant ophthalmologist specializing in medical retinal disease at Manchester Royal Eye Hospital and professor of ophthalmology and interface technologies at the University of Manchester. His research has led to a spin-out medical technology company with awards for social impact, which is his ultimate research goal. He plays an active role as an advisor to many international expert ophthalmic groups on research and clinical care. For my conversation with Tariq earlier this week, what really struck me was how he effectively balances the rigorous demands of the practice of ophthalmology with adaptability and a willingness to explore new horizons to provide optimal patient care. With the current state of the pandemic, these are qualities that are apt for today's conversation, and we welcome Professor Tariq Aslam. Tariq, I hand the floor over to you.
Thank you very much, Pri. Thank you for that introduction. Now, I'm just going to share my screen and get my slides up. So hopefully you can see my first slide. Can you see it right? You're nodding. Okay, that's great. Okay. So the technology bit seems to have worked okay. That's always a good start. I'm really delighted to be able to be here and talk to you guys today. My only regret is that I can't see all your faces in front of me. So, you know, interacting in this way in Zoom has some positives, but that is a downside. And I guess I bring it up because the communication side of things is one of the big challenges that COVID has hit us with. I'm going to talk a little bit about diabetes. And when I was asked to give this talk, it actually took me a little bit of time to sit down and work out how I was going to structure things, because my background is working in one element of the whole structure of how we manage diabetes, and that tends to be the end stage, so the patients who haven't been controlled well enough and start getting severe eye complications. So I'm going to start by talking a little bit about that whole network of what we do in the UK. and then about how it was impacted by COVID, and then finally a little bit about what we have done and what we've tried to do at least to manage all that. And apologies for telling you things you already know, but I think we have quite a wide audience. So I'm going to, start off with some absolute basics. So there's two main forms of ways that diabetes can affect the eye. And one of it is by causing new blood vessels to go around the eye. And these new blood vessels can bleed. But the reason I bring this up is that you can start having these vessels grow and not notice any changes. And so it's really important that there's some sort of service whereby patients with diabetes are screened so that if these new blood vessels show up, they can be treated early. We want to catch these patients before it causes vision loss. And that's a really important thing to be able to do. The second, and one of the key things we do to be able to tell for sure if there are new vessels is this test, which is a picture of the back of the eye done with what we call a fluorescein angiogram. So we inject a dye into people's arms, and then we take photos and we watch the leaking happening. And you see those bright spots, that's where there's leaking areas, and that's because those are new vessels that have grown because of the diabetes. The second main way that diabetes affects the eye is much more in the center of the vision. So it's caused by fluid buildup in the center of somebody's eye. So if you're looking at somebody, most of the center bit of where you're looking at is focused on a part of the eye called the macula. And this should be nice and flat, but you can see in this picture here, there's this these little round black areas. And you can imagine these being like a sponge expanded, and that's because it's expanded with fluid caused by diabetic damage to blood vessels that makes them leak. Now, unlike the new vessels, this happens centrally, so it does affect somebody's central vision, and people would know when they get this sort of diabetic change. I mentioned how I'm a very small part of the service we have for treating diabetes. And this is the main part of it. In the UK, we have this big diabetic retinopathy screening service. We've got around about 3 million patients who go through this. So all patients with diabetes have an eye screening. And it's graded depending on how much we see. If we see a lot of problems, they're seen more often. If they don't have so many problems, they're seen less often. And they can be seen outside of the eye hospital in mobile units. There's photography taken, and there are trained graders, not ophthalmologists, but graders, who can send patients in to hospital if they see issues. So finally, we get into the stage of when I actually see patients. So we have two ways of treating patients, essentially. One is with laser. And this on the left is a picture of the back of somebody's eye with lots of little laser burns. And on the right-hand side, you'll see a standard laser machine. Now, I remember when I was a trainee feeling slightly disappointed because I thought I was going to see this really cool laser, and I was still in my James Bond mode, thinking there would be some really amazing bright light that would shoot out and burn up all the problems it saw in front of it. But actually, it's a tiny, tiny little, very low powered shot of light that's pretty much invisible. And if you put a little bit of tissue paper here and you shot the laser to its maximum power, you could just about see an impact on the tissue paper. So we're not talking about the sort of high-powered lasers that you see in Star Wars or Star Trek, but a really, really fine sort of form of laser. And this form of laser is predominantly the treatment for those new vessels that I talked about. If they can have this laser, it stops those new vessels from bleeding. The other big way of treating patients, which is taking over now a little bit, is this, which is injections into the eye. It sounds not very nice, and actually though, most patients say when they've had it done, it wasn't as bad as they thought. It's a very, very tiny needle, and there's anesthetic given to the eye, and we put a little drop of that in, and then it's injected in, and it takes just a few minutes to do that. And that clears up that fluid at the back of the eye. You remember when you're looking around, and I said there's a part of the eye called the macula that light gets focused on. If you're looking at somebody's face and your macula had fluid, it would all appear a bit wibbly wobbly. But if you have these injections, that can make the blood vessels tighter, and so the fluid doesn't leak out, and you can see much better again centrally. It also has a great impact on the new blood vessels as well. So it really is a wonder drug that we have now that's just come on in the last decade or so. Okay, so what happened with COVID? Well, when COVID first came on, for me at least, it seemed to come from nowhere. We'd heard rumors of things happening, but this was an amazing occurrence that I'd never thought was going to happen, and just took everybody, I think, by surprise. It affected the whole of society, and so all of a sudden we had to make some very rapid decisions that we had no precedence for, and we had to make changes that to our service, and these were the priorities. We suddenly couldn't see as many patients. We had to prioritize the key conditions, of which diabetes and age-related macular degeneration in eye disease were two of the key ones, and at the same time ensure the safety of staff and patients. And patients, from their perspective, we were seeing two aspects. There were some who wouldn't come in because they were frightened of getting COVID, but there were some who desperately wanted to come in, and they were the opposite. They were frightened of missing treatment. And so one of the key things that was really important was communication. Of course, communication without seeing patients face to face has its own challenges. And finally, we also had this problem of healthcare worker well-being. So apart from all these things, for example, for me, when COVID first came, I wasn't sure if I was going to be told that I need to down tools as an ophthalmologist and move over to work in respiratory medicine. I genuinely went to my library and had to dust off my books from medical school from when I used to work in general A&E, because I wasn't sure if I might be told the next day that's where I was needed. So that was there's a lot of anxiety from all sides. But the impact it had was we had reduced clinic slots, and this is more of an impact now. It's still ongoing. Where patients need to be separated, we can't have lots of patients in a single waiting room, and there's lots of cleaning that needs to be done between patients, so our capacity for seeing patients is reduced. And we also have nurses who've been taken away to other challenges brought on by COVID in the respiratory wards and in vaccination programs. And so overall, we have a reduced capacity for seeing patients. On the patient side, some of the patients are not attending as often. And there are a variety of reasons for that, partly fear of COVID, but other things indirectly COVID has caused, such as transport problems. So we don't have all the answers, and our situation is changing all the time. We have changing levels of anxiety in the population, changing levels of lockdown. But essentially, we are trying to make sure that we're still seeing the urgent referrals that the Diabetic Retinopathy Screening Service are doing. And patients also can see their optometrist, and their optometrists know that they can send patients in if they see something urgent. We look regularly at the patient list, patients who are waiting for appointments, and try and go through and identify which patients might be more urgent so we can prioritize them. But we also are depending more and more on virtual clinics, where patients will have imaging done only, but a lot of patients can be seen with that imaging, and then ophthalmologists or optometrists can observe those imaging at the later stage. So they're seen basically for the imaging, and we look at the imaging later on and work out what needs to be done for patients, and then only bring the patients in for the hospital doctors who actually need to have some treatment. Patients who don't turn up, we're working harder to phone them up and try and reassure them that we have lots of measures in place to try and ensure their safety when they are in hospital. And the ones we can't contact by phone, we try and write more detailed letters and try and explore through their general practitioners, the family doctors, how we can get through to them. And this wouldn't be one of my talks if I didn't talk about technology in some way or other. The laser machine I showed you might have seen that the little burns were very, very regular, and we're pleased to have the latest forms of laser machines because that really helps in how long it takes to put on the laser to treat these patients. It means we can treat more patients per session. We're also using more anti-VEGF agents, more injections, because we're seeing patients who are at a later stage of diabetes than we would have otherwise. So the later stages of diabetes is when there's lots and lots of new vessels. Normally we would be straining, looking at a screen, saying, are those new vessels or are they not new vessels? And maybe they're new vessels, let's give them some laser. Whereas now we're seeing more patients coming in who have got masses of new vessels, and the new vessels are already causing problems with things like pressure in the eye. And so for those, we can't even wait for the laser to have effect. Laser would normally take 6 to 8 weeks to have effect. So we're having to give anti-VEGF injections so they can have an immediate impact, and then also do laser as well. So those new technologies and drugs have really, really helped in this crisis. The last thing I want to talk about in terms of tech is this newer form of imaging. So the first image I showed you was one that was produced by injecting the dye into somebody's arm into their veins and taking photos of the back of the eye. And you can imagine that that's not a very straightforward or simple procedure because you need a needle for one, and so you'll need to be observed. And the procedure can take a whole morning to get organized. This is a scan done with a scan called an OCTA, and that's just you putting your chin on a rest and somebody takes a photo that takes 30 seconds to do. And we can still get lots of really useful information on a patient's eye from just this scan. And we can predict if they're going to develop these new vessels very easily using this scan. So we're using a combination of all those technologies now to try and make our service more streamlined and more effective in the face of the COVID issues that we have. And this is another picture of somebody with an OCTA scan. I'm not going to talk a lot about this slide, but this might be something for the future where we're working on artificial intelligence algorithms that look at the photographs on the really incredible images we have and can learn how to deal with different patients. So in the future, maybe what we'll have is less need for doctors to look at the images, but an artificial intelligence algorithm can look at it and screen much more patients and more effectively. I'm going to go past this. So how are we doing things? To summarize, I guess what we're trying to do is doing what we can in the situation we have. It's always evolving. So what we're doing today isn't the same as what we were doing last week, and probably won't be what we're doing in a month's time. But in general, we're trying to move towards more virtual consultations. We're trying to keep this network going, which has the screening and can send patients in who are urgent. If we can streamline things with avoiding unnecessary investigations would be good. In the future, maybe home monitoring and artificial intelligence might be useful. But underlying it all, for me, the key theme that comes through for all this is trying somehow to maintain good communication, whether it's phoning patients or having websites or web information to patients to reassure them. Good communication is one of the cornerstones, I think, that we need to have moving forward. which is why this town hall meeting is also an excellent idea. And I'm very grateful for the opportunity to come and speak. And that's the end of my talk. So hopefully you're still there and haven't all switched off. So Priya, I'm going to hand over back to you now. Do I need to do anything on Zoom or?
Yes, it
Oh,
would. I think you need to stop screens. Right. Okay, thank you for the talk. And yes, communication, I think, has been really highlighted, especially during COVID. So thank you for putting that in bold. Very important. We have questions here from Catherine Klein. Catherine, would you like to ask your question?
Sorry, I had to unmute. Yes, since so much is predicated on these days virtual communication, how do you deal with the many patients, particularly older, poorer ones who don't have technology to do that?
Catherine, that is an excellent question. Well, firstly, and you know, your input on this is really useful as well. So I'll give my answer, and then I'd be interested to hear your thoughts, because sometimes what doctors think patients need isn't actually what they need. So that's one of our research studies that we did, was to look at the sorts of things patients worry about, and we found actually that we weren't always right in the sorts of needs and fears they had. But getting back to your question, we also did a study looking at IT use, and we found that more patients than we thought actually did have access to IT, but there was still a proportion of patients who didn't. We all in some centers, I know at Moorfields Eye Hospital, they have a system where they have video conferencing. We still rely a little bit on old-fashioned phone calls and letters. So I suspect for our population, none of our patients will be at deficit because of a lack of IT at the moment. We may try and move forward for more virtual type clinics where we can maybe assess them in their own homes. But at the moment, we need them to have some specialist imaging. So it's not like a dermatology or some of the general medicine field where we can look at things on a screen. We sort of need to have them specialist imaging. So for that specialist imaging, they sort of have to go to a specialist imaging center. So we're still doing things by phone calls at the moment. I'm interested in what you think, and what is it like for you in your situation, Catherine?
I'm unmuting. I'm going to defer
Okay.
to those who have more experience than I do, but I do know that worldwide, the whole issue of technology and its lack of availability is critical. And what you need are real images. So I was thinking
Yeah,
about, what about rural poor people? I mean, obviously in the
yeah,
UK with your system of healthcare, it's different.
yeah,
And I don't know if you've worked in other
yeah,
locales, but
yeah,
how do people, for example, in rural Africa deal
yeah,
with the issues that you've been addressing?
yeah. Well, you're exactly right. We're very lucky in the UK to have systems we have. I do know of programs that are going on in Africa. So there's a really excellent research project called Peak Vision, where managed to attach they've managed to attach cameras to smartphones, and surprisingly, quite a lot of people in Africa um, are able to use, even in the more rural areas, do have smartphone access, and they can use these cameras that are attached to phones, and they can get images of the back of the eye, which aren't as good as our images, but are still useful. So there are programs underway to try and deal with that. I suspect that it's a really big challenge, and I don't know how COVID on top of that has affected that. I don't have experience of that. I know there's research going on.
We have another question, Tariq, from Cynthia Stewart. Cynthia, would you like to ask your question?
Yes, thank you. It's wonderfully refreshing to hear an ophthalmologist who cares so much about good communications and quality of life issues, but I'm wondering about the provision of low vision services for your population, particularly during the pandemic.
Yeah, so we have our service is based a lot on optometrists at the moment. So we started off probably where patients would come in and see an ophthalmologist who, a nurse might check the vision, but then they'd see an ophthalmologist who would pretty much see them, look at the scans, and then give treatment. And over the last 5 years or so, with such a massive demand, our service has changed a little bit so that now, in most of the clinics I do, for example, there'll be me, I'll be the only ophthalmologist, but there will be optometrists seeing patients, and there'll be a nurse actually doing injections, and then a nurse checking visions and stuff. So it is a multidisciplinary approach. We do have a separate service for low vision. And Cynthia, your question is really good because we do have a service for low vision, but I suspect we probably don't refer patients enough to it. And I think what happens sometimes is that we're so focused on getting this injection in that we don't ask the patients about the general problems they're having or not having. And I think you're spot on because I think we're missing a trick to not do that. As one of my areas that I try and talk to ophthalmologists about, and I'm sometimes disappointed in that some of the ophthalmologists I speak to aren't as interested in this because I'll go to conferences and there'll be lots of text and we'll talk about machine learning and computers, but there'll be relatively few talks on actually talking to patients and finding out what makes them sick and what is going to help them. So we've just started this process. We're starting it off in AMD patients, but we hope to move to diabetic soon, where we want to actually start this conversation going on. Because sometimes what I find is I'll say to a patient, how are you today? So I'll say, hi Cynthia, how are you? And you, my patients at least, will always say, I'm fine, thank you, doctor, and even if they're not fine, they will say they're fine. It's a British thing. It's probably a global thing as well to some extent. And so I never actually find out what's going on until something down the line, there's some questionnaire, and it can be very late. And then I'm sometimes kicking myself that I've not spotted something earlier. So we're trying to produce some questionnaires where we're asking people physically to write down on pieces of paper, just tick boxes. So I think part of it is allowing people to express the issues that they're having and then be able to provide that low vision service. So we do have a low vision service. I think the capacity has reduced, but I think also we probably need to think more about referring patients to it and finding out which patients would benefit from it. We're probably underusing it. So it's a challenge for all those reasons. And I think it's probably better for us than in other areas. I think other areas probably have it even worse, because I think it is a really crucial aspect of care that we sometimes miss. And I feel bad now that I didn't include it in my slides because I will naturally tend to think of all these lasers and injections and things. But you're quite right. It's a really crucial aspect of care that we sometimes miss.
Sorry, I was on mute. I was saying thank you. And we have a question from Jane.
Thanks, Tariq. A terrific presentation. Thank you. In times of COVID, but also before, in the field of older people and ageing, we often talk about inequities. And so I'm really interested, particularly in the location that you work, what are the social and cultural influences that may impact or alter the way that you're able to work with older people and vision complications?
So Jane, I knew this was going to be a difficult question when you were. So you're quite right. I think my underlying philosophy is to try my best to tailor treatment to patients. But to do that, then we need to know patients, and to do that, we need to spend a little bit of time with them. So that is a challenge in the clinic when I've already said, we're having less time to try and deal with these things. So the sorts of things that we see straight away are patients not attending because of fear. And so what we try and do with them is phone them up and speak to them about it. So that can be worse in certain groups, but actually uh, there can be inappropriate fears in the more educated groups sometimes with things. They can be actually more anxious sometimes. So it's not necessarily associated with poverty. And then the other aspect we have in the UK is that we've got, especially in Manchester, a real diverse ethnic mix. And for example, one of the problems we have is Muslim patients with Ramadan and the problems that that can lead to with them not coming in, even worse, not taking their insulin and having lots of really bad diabetic complications associated with fasting. So I can't say that I've got it all figured out, but I think it's a really good point that there is this, there's a massive difference between patients. We go by clinical trials. The clinical trial will take 300 patients and show that overall they will benefit from this treatment or that treatment. But the reality is that with individuals, there are so many differences between them that if we don't think further about the details of why they might or might not be attending, or how they're feeling about their treatment or their fears and anxieties, then we will be missing a trick. I suspect probably more work needs to be done on those individual differences, and I know that that's one thing that yourself and some of our colleagues are working quite hard on. Do you have any insight, Jane, more?
Look, look, we have insights. IFA has insights from another body of work on vaccination. And one of the critical pieces that we found is that the public health messages in vaccination assume a level of health literacy. They assume that we're all of the same literacy. And so, I think that it's important to understand, whether the messages are being read and understood, and whether the messages actually translate into action. And I think that's a fairly cost neutral, area that we could look at. I think the other thing, Tariq, is, in times of COVID, we know that we're not reaching those who are unreachable. So, and our concern at the IFA is that, with the policies generally around the world with, lockdown or this terrible word of cocooning that's come in the UK, then, there's going to be a real concern for older people to even leave their home. And I think so it's a kind of a layered effect. And then that also impacts, the mental health of the people that we deal with.
Yeah, so, and I'm hastily scribbling things down that you're saying. I think you're right, is that our government policy, I suspect around the world, tends to be to have a single message. So for us, pre-COVID, it was 5 a day, stay at home, wash hands, save lives, a single message. But actually, what they're beginning to find more is that we need to have a little bit more nuanced messages for different ethnic and social groups, just as you say. So for the Afro-Caribbean community, they have had a very low, for example, vaccination uptake and possibly missing their diabetic appointments. And that has been thought to be a matter of trust. So we've had very prominent people from that background going on the media and trying to influence people in that way. The Asian community, for example, have had fears that the vaccine somehow contains pork. And so, there are lots of things that are also with the social media that are coming out, spreading rumors that it's sort of, it's a battle, it's an ongoing battle, isn't it? But a single message for all communities is not going to be as effective, like you say, as sort of breaking it down and trying to individualize things, because we're all complex people. I mean, I'm relatively simple, but
Yeah.
other
Yeah.
people can't.
Yeah. With Supriya's permission, can I just ask another question, which is completely different, and then
Absolutely.
zip. You know, it's the conversation about masks, and you know, I talk from my perspective, going to an ophthalmologist. It's really difficult. You know, you've got a mask, you've got perspex to even get to the receptionist. And I've found that the eyes don't do it all, you know, the facial expressions. How are you managing that in your day-to-day practice?
With great difficulty, Jane, because I'm like you. I'm loving the people who have got their screens on. I just like seeing people's faces. You know, I like to see that when I'm giving a lecture, I need to know that they're awake for a start. You know, and listening. And it's just fascinating looking at the nuances of this and that, and you can tell so much from a consultation, not from words, but from their actions and things. And the mask is there and it's hiding, and the patient can't also see that you're interested. They can't see that you want to do the right thing, and that you're concerned. So then it's hard to build up trust. I sometimes ask them to take the mask off when I'm examining them, because otherwise it steams up my lens and stuff. So I have little windows here or there where I can get past things. But I don't have an answer to that unless we can find the masks where, you know, maybe we should be using those transparent ones a bit more. Because I do agree, being able to looking somebody's eyes is one thing, but if you can't see whether they're smiling or grimacing.
No.
That makes it very difficult. I don't know what I'd be really fascinated to hear if any of the audience, patients wise, what they think about that, if that has affected them.
It's interesting. Patrick Slaney. Patrick, would you like to sort of share your experiences? I know I'm putting you on the spot, but you've shared them with me. Are you there? He's probably just stopped and gone away. Cynthia, you've recently been to an ophthalmologist.
Well, I just I'm very maybe shifting gears a bit, but just very perplexed about what I know from working in for an organization that provided low vision, the importance of its quality of life and the number one research issue is, from a patient's perspective, is why didn't my doctor tell me about these resources? And that continues. I mean, that's old research from the 90s, 80s, of it's like the more specialized we get, it's wonderful. And I'm a patient, a glaucoma patient, and so I'm very aware of contrast and lighting and those sorts of things that I can take on for myself, but many people don't have that access. And for your population, for example, with macular edema, the safety issues, cooking when you don't have your central vision, mobility issues when you don't. I mean, there are all kinds of quality of life issues. And I just feel like COVID and the pandemic has probably put all of that on hold. But the number one issue is how do we train people to be all the different disciplines, to recognize that these are quality of life issues. And I mean, if the pandemic taught us anything, it's social isolation rose to the top, that older people are desperate to not be so isolated. Well, it's the same thing. You're sitting there, perhaps you can't read anymore. Okay. And if, like as Kathy Klein said, you don't have the technology, and learning the technology when you don't have central vision is another major challenge. So I just wonder, what opportunities can we take to step back during this pandemic and just rethink it all, so that, again, we truly are patient centered and we're listening to the patient, but the patient may not know of all the things, but we can hear their frustration. I can't do this anymore. I can't thread my needle anymore. I can't use the microwave anymore. Well, there are solutions to all those things. So I'm sorry, I just sort of, you stimulated so much
Yeah.
thinking with this. Thank you.
Cynthia, I absolutely love what you're saying, and I'm getting goosebumps, and I want you to actually just grab you and bring you back. If I could just grab you there and just bring you over to Manchester, because I couldn't agree more. I don't have the solutions, but there's something in the whole of the infrastructure, the economics, and you know, delivery of a service that makes people get very focused on things which are important. So it is important, for example, we give people these injections, and then a layer on top of that becomes, so let's say that the government's paying for the injections, they want to see that these injections are getting in a lot. But and so have an outcome, and the slides I showed you were all outcomes of images, and that's what we do in ophthalmology. We have images. We show this macular edema has gotten less, and everybody will clap. We sometimes don't even say that the vision's gotten better. We'll just show this image. This was the other image. This is the new image. But what the only image which is actually important is would be one of the patients who's now smiling who wasn't before. You know, we don't do that, and I don't know 100% how we've gotten to that stage. I know the sorts of pressures that have led to it, but I couldn't agree more that that's not right. And the only thing I would say is that I only started really thinking a little bit more about this about 5 or 6 years ago, because up till then I was technology, let's get this. And I had a patient who was coming in to see me, and she was always happy and smiling, and she would always joke with me as well. She'd tell some jokes. And as we gave her this super duper new research treatment, and it was only because she was part of the trial that we also gave her a questionnaire. And it was a questionnaire quality of life. And, you know, before I looked at the results, I was sort of thinking, right, she's got 6/6 vision, 20/20, how you would say, and she doesn't even need injections with this new therapy. She's going to be delighted. And I looked at the questionnaire, and she wasn't happy. She was actually depressed. She was actually clinically depressed. She got to the stage where she was so unhappy she wasn't even leaving the house. You know, this was clinical depression, such that she didn't take enjoyment from anything anymore. She didn't find fun in anything. She no longer cared about her appearance. And I was shocked, and then embarrassed, and then that's when I started trying to look more at patients. And I think it is a really crucial thing, because we can't just expect that if we're giving a treatment that makes that macula look a little bit better on the images, that we're doing everything we can. Because I agree with you, there are lots of other things that we can be doing. The challenge is to maybe, I think, get the service providers, the people who are paying for things, to have those as outcome measures. Maybe if we did that, then that might lead to more of a institutional change, because at the moment the clinics are really busy. And I know when I go into a clinic, it's almost like I've never been in a war zone, but it feels almost like, okay, we have 40 patients, right? How's the imaging going? How's the vision going? Who still needs injections? Right? Somebody wants to see me specifically. I have to talk to them, and you know, and then I want them to finish at this time because such has to pick up a child from nursery, you know, and so and so naturally what happens is you end up focusing on the specific treatments, but so somehow we have to try and change that. What we're trying to do is to keep that running, keep the injections going at the same rate, but pick out those people who could benefit from the extra work. So we have started this program now where we give this initial bit of screening just with this little questionnaire, and and it's just a couple of questions, but if something's picked up on that, they're given a little bit more time, and then they can get you know, if it looks like it's needed, then they'll go to, we have this like a whole counseling support service, and we can talk about visual aids and things like that. So for us, it's a challenge because we couldn't do that. If I said to our doctors, everybody needs to do that with every patient, they would, you know, I've never been more heckled, for example, in a talk to ophthalmologists as I have when I talk about patient well-being and trying to see people as a whole, because there's so little time in clinic and people feel so much pressure already of getting things right, getting the right treatment, that they're averse to taking on more roles. They see it as a bigger role, whereas I want to see it as the same role, you know, because ultimately, if you're not improving the patient's quality of life, what are you doing? You know, so it should be the same role, but it's about, I guess, trying to convince all people. Now, when I started this questionnaire, there was resistance from all the different groups about how it might slow things down, and we're not qualified to this. We're not, so it is a challenge. I think it's about changing culture, and I think it needs to come from a lot more directions, a lot more people like you speaking up about it and talking about it, and Jane's work and spreading the word, I think, and trying to gradually implement change in that direction. So the challenge will be, you know, there's so many patients and fewer space, to try and do it in a way that doesn't also limit the essential treatments that are improving vision.
Right. Tariq, thank you for the responses. I had a question and a comment. When you made the remark about patients during Ramadan of Muslim populations, there's one particular resource that I wanted to share with everyone, is that the International Diabetes Federation has come up with these practical guidelines for patients with diabetes who observe Ramadan. So I'll post that resource in the chat. And the question that I had, was coming to, you know, civil society and all the organizations, patient advocacy organizations. As an ophthalmologist, can you make a comment on a specific, you know, a disease area or a demographic that you think requires more attention, that we as a society can actually bring attention and place it on global agenda at high-level meetings?
Well, so there are some things that are on global agendas already, which are rightly so, which are things like application of artificial intelligence and new technology. They're already being looked at a lot. But if I had to highlight one area that I think should be higher up, I would have to say it's Cynthia Stewart, and you know what she's saying about the treating patients. I think, you know, as a whole, thinking about their whole well-being and not just seeing them as looking at them as a scan. Now, you know, all ophthalmologists know that, but we need to somehow be given the space to be able to cover those things as well. And sometimes it's not seen as, if I can use the word, it's not seen as, you know, sexy research or the most cutting edge stuff. It's maybe some people consider it as boring or you know, it's you know, when we talk about robots and artificial intelligence, you know, I've given these talks. So at the last big conference I was at pre-COVID, I organized 2 symposiums. One of them was artificial intelligence and technology, and the other one was on patient well-being. And in the artificial intelligence symposium, they were both in the same room but on at different times. In the artificial intelligence symposium, it was absolutely packed out. There was no space to sit, so there was standing room only, and people were like, it was like a rush hour in the underground. And then in the patient wellbeing symposium was pretty much empty. In fact, it was just the speakers who were going to be talking and a few others dotted here or there. And the following year, that symposium didn't go ahead. I think it was, you know, it was deemed to be not interesting enough for the population. And actually, it probably should have been the other way around, because, you know, from my perspective, nobody in the AI symposium would have come away with something necessary that they could use the next day. But if they'd been in the wellbeing symposium, they could have come away with something they could have used the next day that might have improved things for their patients. So I think a rebalancing of the importance of the sorts of things that Jane and Cynthia have talked about, would be a really useful thing to do. It's just not talked about enough. I think there's a gradual, in the UK at least, there seems to be more of a acceptance of talking about things like mental health and well-being. But it's still, I think, a little bit pushed aside too much and not talked about enough.
Yes, absolutely. I completely agree with you. And thank you for highlighting that issue of how important mental health is. Now, I wish we could continue this conversation with you, Tariq. Your talk has been an eye-opener. So as we come to the end of this town hall, I'm going to make a few closing remarks and then I'll hand it back to you. Excuse me. Sorry about that. So first of all, I'd like to thank you for your informative comments and for your time. I'd also like to thank Ashni Patrick, our Media Marketing and Communications Officer, for her help with the town halls, and Dr. Jane Barrett, IFA Secretary General, for her leadership and support. There are a couple of housekeeping that I'd just like to focus for a few seconds. So as you can see, and most of you all know, the IFA's 15th Global Conference on Aging will take place between 9th and 12th November 2021, both in person and virtual in Niagara Falls. During the conference, the Presidential Symposium on Vision Health will bring together a global network of peers in the aim of conveying the importance of integrated care. Registration is open, and this is an opportunity to attend and learn about the latest global evidence in vision health, emerging policy issues, and the role of civil society in improving healthcare outcomes for all. My next order of business is our speaker for the month of May. Our speaker is Professor Richard Gale, consultant medical ophthalmologist and clinical director at York Teaching Hospital NHS Foundation Trust. Professor Gale will be speaking to the importance of effective patient communication during the pandemic, and I encourage everyone to register and attend next week, Thursday, May 6th. And Tariq, the floor is now yours for final comments.
Thank you very much. So once again, thank you everybody for this opportunity to speak to you. It's been really interesting for me, and one of the reasons I agreed to do talks is because I always learn from preparing it and from doing it and from feedback. So it's been great for me, and I hope that you found it interesting as well. I would recommend Richard Gere for the next session. He's a fantastic speaker. I recommend that session. And I guess the thing that's come out from this for me is the importance of communication. And I need to try and push, and we need to try and push as doctors on that side. From your side, as you know, potentially as patients or other people involved in the health service, I think it would be a good idea to try and be more forward if you do have issues, to try and maybe write them down and say that you want to speak to these, talk about these with your doctor. And if they're a good doctor, they'll want to know, they'll want to listen. They may not have understood or appreciated it, but if you do express these things, then maybe things that they can help you with. So that take-home message from me, I guess, would be the importance of communication from both sides. And I wish you all the best. And it was great again. And thank you for listening.
Thank you for a really informative talk, and thank you for your final messages. And we look forward to talking more with you in the future. And thank you to everyone for being a part of this town hall today. And we will see you next week, Thursday, 6th of May at 7 a.m. EST. Right, thank you.
Thank you, everybody.